Welcome back to the Deep Dive, where we take complex source material and distill it into, well, immediately useful knowledge. Today, we are taking a truly advanced look into the highest level of neonatal care. We're specifically mastering the critical definitions, diagnosis, and specialized management of small and early babies. This deep dive is designed for you, the learner who seeks to command this information like an elite professional.
Indeed. And we are examining a wealth of quite sophisticated clinical and diagnostic information. It's rooted firmly in obstetrics and neonatology. Our goal today is really to move beyond those simple definitions of a small baby. We want to grasp the fundamental, often life-saving difference between constitutionally small infants and those whose growth has been pathologically restricted. And this distinction, as our sources really emphasize, it's not just academic. It's absolutely vital for accurate prognosis and, of course, effective management.
Okay, let's unpack this then. Our source material lays out three interconnected but distinct concepts we really must master. First, low birth weight, or LBW. Then preterm birth, PTB. And finally, fetal growth restriction, FGR. Our mission today is comprehensive. We need to understand the precise clinical metrics, yes, and the cascade of severe risks associated with this systemic immaturity. Plus, the highly specialized protocols required for their immediate survival and, importantly, their long-term health.
Exactly. We'll begin by anchoring ourselves in the fundamental terminology, correlating weight and age. Then we'll transition into the anatomical manifestations of prematurity. What do these babies actually look like? And the critical systemic risks they face, particularly focusing on the central nervous system, the CNS. Following that, we'll move into the step-by-step management protocols. And we'll culminate in a deep exploration of the advanced biophysical and Doppler monitoring used prenatally. Because that's what helps make those crucial delivery decisions for the growth-restricted fetus.
Right. We must begin, as you said, by correcting maybe an older way of thinking. The historical approach, the earlier concepts of prematurity, they hinged solely on birth weight, didn't they? Less than 2,500 grams. Why did the medical community realize this weight-only definition was, well, fundamentally insufficient for predicting a baby's outcome?
Well, it was insufficient because it was clinically, frankly, pretty useless on its own. Survival and morbidity, they really depend on a synergistic relationship between both gestational age and birth weight. Think about it this way. Consider two scenarios. You might have an infant born at 41 weeks, full term, maybe even post-term, and maybe they weigh 2,400 grams because they're just constitutionally small, but they're fully mature. Okay, now conversely, you could have a baby of a diabetic mother, maybe weighing 3,000 grams, but born at 36 weeks, and that baby could suffer severe respiratory distress because their lungs are immature. So the 2,400-gram mature baby, fantastic prognosis usually, but the heavier premature baby, despite the higher weight, is critically ill. The original system just failed to correlate immaturity, the time factor, with growth, the weight factor.
Yeah.
And you absolutely need that correlation for accurate risk stratification. It's essential.
Okay, so the modern approach introduced this crucial framework. It uses percentiles tailored to the exact gestational age to define the growth status. That makes sense.
Precisely. And this framework is, well, it's fundamental for how we talk about these babies now.
Yeah.
We define three main terms based on this correlation. One, small for gestational age, or SGA. This is when the birth weight is less than the 10th percentile for that specific gestational age. And importantly, this category includes babies who are simply genetically small, constitutionally small, but otherwise healthy.
Okay.
Two, appropriate for gestational age, AGA. Here, the birth weight lies robustly between the 10th and 90th percentiles for their gestational age. This represents normal expected growth.
Standard range.
Exactly. And three, large for gestational age, LGA. Here, the infant's birth weight is above the 90th percentile for gestational age. You often see this, as I mentioned, in infants of diabetic mothers. And LGA status can present its own set of unique risks, too, though that's perhaps a topic for another deep dive.
Right. So this framework allows clinicians to really differentiate, doesn't it, between a baby who's just constitutionally small and one who is pathologically growth restricted. But separate from that correlation, the World Health Organization, the WHO, they maintain a classification based purely on weight. And that remains crucial for epidemiological tracking for global incidence data, right?
That's absolutely right. And it's important to keep these separate in our minds. When we use the WHO classification, it's purely about weight, irrespective of age. First, low birth weight, LBW. That's less than 2,500 grams, still the fundamental baseline indicator globally.
Okay.
Then, very low birth weight, VLOBW, defined as 1,500 grams or less. These infants, they essentially require mandatory intensive care. And finally, extremely low birth weight, ELBW. defined as 1,000 grams or less. These are the most fragile infants, needing the absolute highest level of technological support we can offer.
Okay, now let's drill down on preterm birth, PTB. This one is strictly a measure of time, isn't it?
Yes, exactly. Preterm birth is defined simply as birth occurring before the completion of 37 menstrual weeks of gestation. Full stop. The critical point here, and this often gets confused, is that a preterm baby's growth potential might have been entirely normal up until birth. They could be appropriate for gestational age, AGA, falling nicely between the 10th and 90th percentile for their age, but their systems are biologically immature simply due to arriving too early. And that's why a 2,000-gram preterm baby born at, say, 33 weeks often faces far, far greater risks than a 2,000-gram term SGA baby who's just small but mature.
That makes sense. And the incidence contrast mentioned in the sources, looking globally, it's truly staggering. It serves as a sharp reminder of global health disparities.
It absolutely does. Preterm birth is a massive contributor to global neonatal mortality. It constitutes, get this, 2/3 of all LBW babies worldwide. Now, in developed countries, the overall LBW incidence is often less than 10%. But you look at developing countries, the overall LBW incidence can skyrocket to 30, even 40%. And within that, the PTB incidence is sitting around 20 to 25%. This huge disparity immediately points towards the critical role of environmental factors, socioeconomic factors, healthcare access.
And the factors influencing this risk are numerous, aren't they? They extend far beyond just the timing of birth itself. Oh, definitely. We have to consider this continuum of risk. Socioeconomic status plays a massive role. I mean, access to adequate prenatal care, proper nutrition, these are paramount. The quality of the nutritional and the intrauterine environment, including the mother's baseline health status, that directly impacts fetal development. Furthermore, ethnic background and genetic control contribute significantly to the overall mean birth weight of a population. And that affects where that crucial 10th percentile cutoff actually falls for defining SGA or FCR. These variables are constantly interplaying to determine an infant's final birth weight and gestational age status. It's complex.
Okay, so when a baby arrives early, the clinical manifestations of prematurity are highly specific, and they directly correlate with the degree of immaturity. For the elite professional, reading these anatomical clues, it's fundamental to understanding the immediate vulnerabilities, right? Absolutely. The clinical features are essentially a checklist of developmental incompleteness. Generally, as we said, weight is 2,500 grams or less. Length is usually less than 44 centimeters. But the key visual sign, which reflects those differential growth rates in utero, is the body proportion. The head and the abdomen are relatively large compared to the rest of the body, and the head circumference disproportionately exceeds the chest circumference. Normally in a term infant, this difference is only about 1.5 centimeters, maybe 2. But in the preterm infant, this disproportion is quite marked. You can see it.
And what about the physical characteristics, the things that indicate structural immaturity?
Yeah, you see structures that are just visibly soft and, well, unprotected. The skull bones are soft, the sutures between them are wide, the posterior fontanelle, the soft spot at the back, is large, and this softness makes them highly vulnerable to dangerous molding, pressure changes during delivery. The pinnae of the ears, the outer ears, they're soft and flat. They lack the cartilage that gives them form. The eyes are often kept closed. The skin is characteristically thin, red, and shiny. That's due to the lack of sufficient subcutaneous fat. And it's often covered by a thick layer of lanugo, that fine, soft hair, or sometimes excessive vernix caseosa, the cheesy coating.
Right, and the functional indicators, those give us clues to the baby's readiness or lack thereof to survive outside the womb.
Exactly. Muscle tone is universally poor. They feel floppy. We look at the feet. Those plantar deep creases on the soles, which are key indicators of neurological maturity, they're typically not visible before 34 weeks gestation.
Interesting.
Generally, maturity is assessed as well. For males, the testicles are often undescended, still high up. For females, the labia minora, the inner lips, are exposed because the labia majora, the outer lips, haven't yet grown enough to cover them. Even the nails haven't grown right up to the fingertips yet. All these indicators together confirm that functional and structural unpreparedness for extrauterine life.
Okay, moving to the complications. This is where the conversation really deepens, I think. The risks are truly systemic, aren't they? Arising simultaneously from organ immaturity and potentially the underlying cause of the preterm birth itself. And we have to remember, as the source points out, even the late preterm infants, those born between 34 and 37 weeks, they still face risks. Short-term complications, yes, but also long-term neurodevelopmental challenges compared to their term counterparts.
Absolutely. Let's start with the central nervous system, the CNS, and the profound risk of hemorrhage. This is really the cornerstone of long-term disability in preterm infants. The functional immaturity means the risk of asphyxia oxygen deprivation is significantly heightened. And critically, even minor anoxia, a little bit of oxygen lack, can produce subserosal hemorrhages in various organs, heart, lungs, liver. But the worst consequence, the one we worry about most, is the intense congestion of a choroid plexus in the brain. This leads directly to intraventricular hemorrhage, or IVH, bleeding into the ventricles.
And why is the preterm brain so uniquely susceptible to IVH compared to a term baby's brain? What's the mechanism?
It really boils down to structural vulnerability. It's multi-layered. First, as we mentioned, the soft skull bones and wide sutures allow dangerous degrees of molding during birth. This shearing force can tear vessels, causing subdural or subarachnoid hemorrhage, bleeding on the surface or between layers.
Okay.
But second, and this is the fundamental problem unique to preemies, it's the extremely fragile subependymal capillaries of the germinal matrix. This is a rich network of vessels deep inside, near the ventricles, that's crucial for brain development, but very weak. These capillaries simply cannot withstand even minor fluctuations in blood pressure or minor hypoxia. They just rupture. And when you combine that fragility with an associated hypoprothrombonemia, basically, impaired clotting ability common in preterms, the risk of bleeding into the ventricles becomes catastrophic. This cascade of events, the IVH, often results in damage to the surrounding white matter, called periventricular leukomalacia, or PVL, and PVL is a leading cause of long-term cerebral palsy, or CP. That's the direct link.
That's a very clear pathway. Moving to the lungs, then, pulmonary syndromes account for nearly a quarter of all preterm cases, the sources say.
They do, and while we certainly see things like pulmonary edema and intraalveolar hemorrhage, often effects of hypoxia, the dominant cause of death, especially in babies born before 34 weeks, is idiopathic respiratory distress syndrome, or RDS. The principal factor here, the underlying cause, is the deficient production of lung surfactant.
Right, surfactant.
Surfactant is this amazing lipoprotein complex that lines the alveoli, the tiny air sacs in the lungs. Its job is to lower the surface tension, preventing those sacs from collapsing completely when the baby exhales. Without adequate surfactant, you get widespread pulmonary atelectasis. The lungs just collapse. This rapidly drives severe hypoxia, low oxygen, and subsequent acidosis, a buildup of acid in the blood. The really good news here, though, is that exogenous surfactant therapy, giving artificial surfactant directly into the lungs, has absolutely revolutionized the prognosis for these babies. It's a game changer.
It really is. However, sometimes the necessary respiratory support, the ventilation needed to keep them alive, introduces a new long-term problem, bronchopulmonary dysplasia, or BPD.
That's the difficult trade-off, isn't it? BPD is a form of chronic lung disease. It arises essentially from the damage caused by prolonged mechanical ventilation and sometimes high concentrations of oxygen needed to treat severe RDS. It's basically an interruption or an injury to normal lung development caused by the very life support that saved the baby's life. We have to be constantly conscious of this risk-benefit balance when treating severe RDS.
Yeah, a constant challenge. Next up, thermoregulation and metabolism. These seem like massive physiological hurdles for these tiny infants.
Huge hurdles. They struggle constantly with heat loss. It's almost their default state. The preterm baby has essentially a threefold deficit in staying warm. 1, reduced subcutaneous fat for insulation. 2, reduced brown fat. That's the specialized tissue primarily responsible for non-shivering thermogenesis, generating heat without shivering. They just don't have much of it. And 3, an increased surface area relative to their small body volume, more skin exposed to lose heat from. Put it all together, and they often fail to maintain that crucial thermoneutral range, the temperature where they expend the least energy. This leads to a constant risk of hypothermia, which itself dramatically increases their metabolic demand, burning precious calories just to stay warm.
Vicious cycle.
Exactly. And parallel to this, we see hypoglycemia, low blood sugar, defined as blood glucose below 40 milligrams per deciliter in about 15% of these infants. This is primarily due to a severe lack of liver glycogen stores. They just haven't had time to build them up. And it's exacerbated by cold stress, sometimes by hyperinsulinemia in certain cases, and often by poor initial feeding.
Makes sense. The cardiovascular and renal systems are equally unprepared, I imagine.
Absolutely. Very common issue. The persistence of the patent ductus arteriosus, or PDA. This is a fetal blood vessel connecting the aorta and pulmonary artery that normally closes shortly after birth. In preemies, it often stays open, and the likelihood is inversely related to gestational age. The smaller the baby, the more likely the PDA remains patent.
Why is that a problem?
because it allows excessive blood flow into the lungs, leading to circulatory overload. This can precipitate heart failure, especially if combined with asphyxia or the rapid onset of pulmonary edema. It means clinicians have to be incredibly careful, strictly avoiding overhydration in these vulnerable infants. Fluid balance is critical.
Right.
And the kidneys themselves are functionally immature. They struggle with concentrating urine effectively. They also struggle with efficiently excreting solutes and waste products. This can lead to issues like oliguria, low urine output, dehydration, and potentially severe acidemia because they simply cannot handle the acid loads produced by metabolism efficiently.
Okay. And the risk of infection, the sources say, is dramatically elevated, a constant threat.
Constant and serious. The infection risk is indeed quoted as 3 to 10 times higher than in term babies. The underlying mechanism is fairly straightforward. The preterm infant misses out on much of that essential passive immunity. That's the transfer of protective immunoglobulins, antibodies, from the mother across the placenta, which occurs predominantly in the third trimester. They just weren't inside long enough to get the full dose.
Oh.
On top of that, their own immune response, both the humoral, antibody-based, and cellular components, is poor. This is compounded by often having a low leukocyte count, white blood cells, and poor phagocytic activity. The cells that engulf bacteria aren't very effective yet. This profound vulnerability leads to serious, often life-threatening complications like bronchopneumonia, meningitis, and the often devastating bowel condition necrotizing enterocolitis, or NEZ. We also frequently see serious infections with respiratory syncytial virus, RSV, which can be particularly dangerous in preemies.
Wow. Finally, in this section, we need to discuss jaundice, apnea, and that devastating long-term sensory complication, retinopathy of prematurity, ROP.
Right. Jaundice, or hyperbilirubinemia, is essentially an exaggerated physiological problem in preterms. It's due to hepatic immaturity. The liver lacks the full enzyme function, particularly glucuronal transferase, needed to adequately conjugate bilirubin, making it water-soluble for excretion. This leads to a potentially dangerous buildup of unconjugated bilirubin, which can be toxic to the brain if levels get too high. Kernicterus.
Okay.
Apnea is periods where breathing stops and the increased risk of sudden infant death syndrome, SIDs. These stem primarily from the immaturity of the autonomic nervous system that controls the basic rhythm and drive of breathing.
But ROP, retinopathy of prematurity, is the complication that seems directly related to our intervention, specifically oxygen therapy. For the elite professional listening, understanding the oxygen saturation target is absolutely critical here. Why does oxygen, the very thing keeping these infants alive, potentially cause blindness? It seems so counterintuitive.
It is counterintuitive, but the mechanism is fascinating and crucial to understand. ROP is a multifactorial retinal disorder, yes, but oxygen plays a key role. It causes abnormal neovascularization, abnormal blood vessel growth in the retina. Here's the critical mechanism. It's about the dysregulation of retinal vessel growth caused by fluctuations in oxygen supply, particularly hyperoxia, too much oxygen. If we administer too high a concentration of oxygen, the source is mentioned above 40%, but really it's about achieving excessive oxygen levels in the blood. The existing immature retinal blood vessels constrict, and some can even die off. This is phase 1, vasoobliteration. This initial cessation of normal vessel growth then triggers a rebound effect. Once the baby is potentially weaned off the high oxygen, the relatively hypoxic retina sends out signals demanding blood supply. But this triggers an abnormal, chaotic proliferation of new vessels. They grow wildly, not in the organized way they should. This abnormal growth, this neovascularization, can then lead to scar tissue formation. This scar tissue contracts, pulling on the retina, causing traction, detachment, and potentially irreversible blindness. This is precisely why the pulse oximeter reading must be tightly controlled within the very narrow window of 90 to 92% oxygen saturation. The goal is to prevent both hyperoxia, which triggers the initial vessel damage, and significant hypoxia, which also stresses the system. It's a very fine balance. #Tag 3. Prognosis and long-term outcomes of LBW in infants.
Okay, that clarifies ROP significantly. Shifting now to prognosis. The immediate chance of survival is statistically mapped, as you mentioned, heavily dependent on weight and age. But you also said the overall vigor at birth, their condition right at delivery, is often more predictive than weight alone. What are the current survival benchmarks we're seeing?
Well, the prognosis is highly weight and age dependent, absolutely. But neonatal care advancements have pushed the boundaries dramatically over the last few decades. Statistically, a baby weighing more than 1,500 grams, the LBW cutoff, is now about 95% likely to survive in a high-resource setting.
That's incredible.
It really is. And with current intensive neonatal care protocols, survival for babies weighing between 751 and 1,000 grams, the ELBW range can reach up to 80%. However, the limits are still stark. Mortality remains acutely high for the most immature infants. It's greater than 97% for gestational ages less than 23 weeks. Viability really starts around 23, 24 weeks. And we know that the majority of deaths, about two-thirds, occur within the first 48 hours of life. This just underscores the absolute necessity of immediate expert stabilization right from the delivery room.
Focusing now on the long-term prognosis. Those early complications we discussed, IVH, RDS, they have profound lifelong implications. This is clearly outlined in our source material, particularly Table 32.1, which listeners might refer to. What's the gravity of the major long-term handicaps these survivors face?
The major handicaps are often neurological and respiratory, as you'd expect from the initial insults. We frequently see cerebral palsy, CP, which can range from mild to severe motor impairment. Hearing loss is also a significant risk. Chronic lung disease, typically in the form of bronchopulmonary dysplasia, BPD, resulting from early ventilation needs, and often poor overall physical growth compared to their peers born at term. When we look specifically at the CNS, the central nervous system, those early complications we detailed IVH, germinal matrix hemorrhage, GMH, which is related to IVH, and periventricular leukomalacia, PVL, the white matter injury. These are directly causative of lifelong issues. Severe cerebral palsy is the most recognized, but also epilepsy, global neurodevelopmental delay affecting cognition and learning, and significantly a much higher rate of attention deficit hyperactivity disorder, ADHD. This is particularly prevalent in infants born weighing less than 2,500 grams.
It's truly remarkable and quite sobering how these early life events, sometimes just in the first few days or weeks, can essentially program the body for chronic adult diseases decades later. Let's explore that concept of developmental programming a bit more.
It's a fascinating and critically important area of research,
How?
the developmental origins of health and disease, or DUTTA. What we're seeing is potentially permanent physiological alteration stemming from that early stress and immaturity. For instance, early cardiovascular distress, like having a persistent PDA or experiencing cardiogenic shock, might actually program the vasculature differently. It seems to set the foundation for developing hypertension in adult life.
Rightly.
Yes. And endocrinologically, the early stress, specifically episodes of severe hypoglycemia or the cortisol deficiency, often experienced by critically ill infants in the neonatal intensive care unit in ICU. This is now strongly linked to increased insulin resistance and type 2 diabetes in adulthood. And of course, the ocular issues. Retinopathy or prematurity, if it progresses, can result in permanent visual impairment, including blindness, but also less severe outcomes like high myopia, nearsightedness, and strabismus, crossed eyes. The bottom line is the long-term prognosis isn't just about surviving the NICU. It requires a dedicated multidisciplinary system of follow-up care for potentially decades.
Absolutely. And the care of the preterm neonate itself, it's arguably one of the most intensive and protocol-driven fields in all of medicine. Because these babies are functionally immature, they often can't suckle or swallow effectively, they can't regulate their own temperature, they're prone to these sudden cyanotic attacks where they start breathing and turn blue. Every single element of their environment must be meticulously controlled to facilitate survival and minimize further injury.
Okay, let's detail the immediate management protocol. Starting literally seconds after birth, what are the absolute first steps? The immediate steps are all about preventing the exacerbation of their existing vulnerabilities. First, the umbilical cord is clamped relatively quickly. This is primarily to prevent hypervolemia, too much blood volume shifting to the baby, which can worsen respiratory distress and also increase the risk of hyperbilirubinemia, jaundice.
Okay.
However, paradoxically almost, the cord length is intentionally kept long. The sources say 10 to 12 centimeters. Why? Just in case future umbilical vessel access is needed, particularly for an exchange transfusion if jaundice becomes severe, you preserve that access point. Then, air passages are cleared very gently. Suctioning is minimal and careful to avoid vagal responses. Controlled oxygenation is provided if needed, but as we discussed, strictly monitored, often starting with a low concentration, perhaps 3 to 5% initially, guided by pulse oximetry to avoid those ROP risks.
And thermal control, you mentioned how critical this is. It's arguably the most immediate priority for stabilization, isn't it?
It is the absolute first non-negotiable step after ensuring the airway is clear. The baby is wrapped immediately and importantly, including the head, because that's a large surface area for heat loss in a sterile, warm towel. The goal is to maintain the target core body temperature range of 36.5 to 37.5 degrees Celsius. And a key point, if the infant is hypothermic on arrival, warming must be done slowly. Rapid warming can cause peripheral vasodilatation and cardiovascular collapse, or shock.
Okay, slow warming.
Finally, in those first minutes, 1 milligram of aqueous vitamin K is administered intramuscularly. This is crucial to address that inherent clotting factor deficit, the hypoprothrombonemia we talked about, to help prevent hemorrhagic manifestations, especially IVH.
Right. Then the ongoing intensive care requires maintaining that perfect thermoneutral condition, which, as you said, is a massive challenge due to their lack of fat and high surface area. How is that achieved technologically?
We rely heavily on advanced technology to create a stable microenvironment. For the extremely low birth weight babies, those under 1,000 grams, they're ideally placed immediately into pre-warmed double-walled incubators, or sometimes under a radiant warmer, often with protective clear plastic covers or wraps. They're usually kept naked inside the incubator to maximize heat transfer from the environment and allow for continuous monitoring. The target skin temperature probe reading is typically 36 to 36.5 degrees Celsius. And crucially, we must address their incredibly high insensible water loss, IWL, the evaporation from skin and lungs. This is done by maintaining the surrounding humidity inside the incubator at a very high level, often 80% initially. This high humidity reduces that evaporative loss, conserving precious water and also helping to conserve heat.
Makes sense. And given those immature kidneys and the high IWL, fluid and electrolyte management sounds like a razor-thin balancing act.
It absolutely is. It demands constant vigilance and frequent monitoring. These infants have significantly increased fluid requirements compared to term babies due to that high IWL and their inefficient renal function. Intravenous fluid therapy is often initiated immediately, especially for VLBW infants. Starting volumes might be around 50 to 70 milliliters per kilogram per day, but this is adjusted constantly based on weight changes, urine output, and electrolyte levels. And here's a critical clinical detail mentioned. If the baby requires phototherapy for jaundice, the fluid requirement generally increases by about 10%. That's because the phototherapy lights generate heat and increase evaporative losses further.
Good point.
And serum electrolytes, sodium, potassium, chloride, bicarbonate, must be monitored very frequently, often every 12 hours initially, to prevent dangerous imbalances like hyponatremia or hyperkalemia, which can have severe cardiac or neurological consequences.
Okay, let's discuss respiratory support more. The protocols seem highly specialized, aiming for a very specific biochemical balance in the blood gases.
Yes, the respiratory management can range from simple supplemental oxygen via nasal cannula or an oxygen head box, all the way up to endotracheal intubation and complex modes of mechanical ventilation or non-invasive support like continuous positive airway pressure, CPAP, or high-flow nasal cannula, HFNC. If invasive ventilation is required, the settings are constantly adjusted based on frequent arterial blood gas sampling or continuous transcutaneous monitoring. The therapeutic targets are very tight, as you noted. We aim for a partial pressure of oxygen in arterial blood, the PO2, typically between 55 and 65 millimeters of mercury. That ensures adequate oxygen delivery without causing the hyperoxia linked to ROP.
Okay, 55 to 65 for PO2.
Right. We manage the partial pressure of carbon dioxide, the PO2, usually between 35 and 45 millimeters of mercury, reflecting adequate ventilation, getting rid of CO2 efficiently.
35 to 45 PO2.
And the pH, the measure of acidity, must be tightly controlled, typically between 7.35 and 7.45, balancing respiratory and metabolic factors to avoid significant acidosis or alkalosis.
7.35 to 7.45 for pH.
And connecting back to ROP, the pulse oximeter readings, which give us peripheral oxygen saturation, must be held strictly within that narrow target range, usually 90 to 92% saturation, as the source indicates. It's constant monitoring and adjustment.
It sounds incredibly demanding. Now, infection you mentioned, it's a persistent multi-organ threat. Our sources actually recommend specific prophylactic antibiotic therapy in certain situations. What does that mean in practice, considering concerns about antibiotic stewardship in the NICU?
That's a really important and complex question. The high vulnerability of these infants to overwhelming sepsis stemming from their low leukocyte count, poor phagocytic activity, low maternal antibody transfer often necessitates immediate action, especially if there's a clinical suspicion of infection or known risk factors like prolonged rupture of membranes.
Right.
So prophylactic antibiotic therapy is sometimes given. The protocol listed in our source is ampicillin, 100 milligrams per kilogram per day, and an aminoglycoside like amikacin, 10 to 15 milligrams per kilogram per day, typically given intravenously for 5 to 7 days, especially following premature rupture of membranes. However, the professional context here absolutely recognizes the complex debate surrounding this practice. While immediate broad-spectrum coverage can undoubtedly be life-saving for an infant who is septic, routine, Repeated or prolonged prophylaxis carries risks. It contributes significantly to the emergence of antimicrobial resistance within the NICU environment. And it can also disrupt the developing gut microbiome, the healthy bacteria in the gut, which paradoxically might even increase the risk of developing NEC later on. So it's a real balancing act. It's a constant clinical judgment call. It has to be informed by local infection rates and resistance patterns, the specific clinical scenario, like proven maternal infection, and a high index of suspicion, rather than just being a blanket routine for all preterm infants.
Okay, that makes sense. Moving now to nutrition and feeding protocols. The initial strategy mentioned is something called trophic feeding. That sounds counterintuitive if the goal is growth. Why is human milk the absolute first choice, and what exactly is the purpose of trophic feeding?
Human milk, whether it's the mother's own colostrum, foremilk or hind milk, or pasteurized donor human milk if mother's milk isn't available, is unequivocally the gold standard for feeding all low birth weight babies. No question. Its components are uniquely suited to the immature gut. It contains growth factors, enzymes, antibodies, anti-inflammatory components. It actively promotes gut development, stimulates the growth of the intestinal villi, enhances enzyme secretion, and improves gut motility. And clinically, this translates directly into decreasing the incidence of critical complications like systemic infection, necrotizing enterocolitis, NEC, and possibly even ROP.
Okay, so human milk is key. What about trophic feeding?
Trophic feeding is the strategy for initiating enteral feeding, usually within the first day or two of life, even while the baby is still receiving primary nutrition intravenously. Its purpose is not primarily caloric in those early stages. It involves giving tiny, measured volumes of milk, maybe just 10 to 20 milliliters per kilogram per day, split into small, frequent feeds via a feeding tube. The goal is to prime the pump, essentially, to stimulate the gut mucosa, encourage enzyme development, improve motility, and promote maturation of the gut immune system. It helps minimize the duration the baby relies solely on intravenous nutrition, which itself carries risks like liver problems.
Got it. So it's about stimulating the gut, not really feeding for growth initially. And the timing is early, you mentioned, partly to combat hypoglycemia.
Yes, exactly. Early initiation of feeding, ideally starting trophic feeds within the first 0.5 to 1 hour of birth if the baby is stable enough, is now widely recommended. This early introduction helps prevent or manage hypoglycemia. It can help lower serum bilirubin levels by promoting gut motility and excretion, and potentially prevent some neurological sequelae associated with prolonged starvation. Feeding intervals are dictated by the degree of prematurity and tolerance. Maybe hourly feeds for the extremely premature, gradually spacing out to every 3 hours for those closer to term, perhaps around 36 weeks.
And the caloric and volume increase must be very gradual, you emphasize, to avoid overwhelming the immature digestive system.
Incredibly gradual. You have to remember the stomach is tiny, the cardiac sphincter at the top of the stomach is weak, leading to reflux, peristalsis is slow, and the coordinating suck, swallow, breathe reflex is often poor or absent. Aspiration is a constant risk.
Right.
So calorie intake must be stepped up slowly. Starting small, perhaps aiming to reach a minimum of 60 calories per kilogram per day by the 7th day of life. Then gradually increasing, aiming for a target of maybe 120 to 150 calories per kilogram per day by the 21st day to support catch-up growth. Similarly, total fluid volume given enterally increases slowly, starting perhaps around 80 milliliters a day, combined with IV fluids initially, and gradually increasing towards a goal of maybe 180 to 200 milliliters a day, fully enterally by the 8th to 10th day, always assessing tolerance.
Okay. And how is the method of delivery chosen? How do you decide whether to use a tube, a dropper, or try breastfeeding based on the baby's functional abilities?
It's entirely determined by the baby's vigor, their neurological maturity, and their gestational age. There's a clear hierarchy. Intravenous fluids, parenteral nutrition, providing all nutrients directly into the bloodstream, is mandatory as the primary source for the smallest, most immature infants, generally those less than 1,200 grams or born before 30 weeks. Trophic feeds happen alongside this.
Okay, IV first for the tiniest.
Then tube. Gavage feeding is used when the baby cannot yet coordinate sucking and swallowing effectively, but can tolerate milk in their stomach. The standard is using a fine, soft polythene tube. The source specifies 0.5 millimeter internal diameter, passed through the nose or mouth into the stomach. Expressed breast milk is then dripped in slowly by gravity. This is typically initiated with trophic feeds after day 1 to 3 for very low birth weight infants and gradually increased as tolerated.
Lavage feeding.
If the baby develops the ability to swallow but still lacks the strength or coordination to suck effectively from a breast or bottle, then manual methods are used as a bridge. This could be using a pipette, a dropper, a small katori, the traditional Indian cup, or a spoon to carefully place small amounts of milk in the baby's mouth, allowing them to swallow it.
Manual methods as a bridge?
Finally, full breastfeeding directly at the breast is generally initiated once the baby achieves sufficient maturity and strength. The typical benchmarks mentioned are weighing more than 1,800 grams or reaching a gestational age of more than 34 weeks, though this is individualized based on the baby's cues and abilities.
That's a clear progression. And since these babies missed out on that final trimester's worth of placental transfer for many nutrients, supplements are essential, aren't they?
Absolutely critical for preventing specific deficiencies that can impair growth and development. Standard multivitamins, including A, D, C, folic acid, B1, and minerals like calcium and phosphate, crucial for bone mineralization, are usually started after about 2 weeks of life, once feeding volumes are advancing.
Vitamins and minerals after 2 weeks.
Iron supplementation is particularly important because preterm infants are born with low iron stores and are at high risk for anemia of prematurity. This typically starts a bit later, maybe in the second or third week, usually at a dose of 2 to 4 milligrams per kilogram per day of elemental iron. Starting it too early can sometimes interfere with other nutrient absorption or potentially increase oxidative stress.
Iron starting second or third week.
And for the most vulnerable, the very low birth weight infants, less than 1,200 grams, who may be on IV fluids for a prolonged period. That comprehensive parenteral nutrition, PSE, was required. This isn't just sugar water. It's a complex 4V solution providing amino acids for protein, lipids for fat, dextrose for carbohydrates, plus electrolytes, trace elements, and multivitamins, carefully calculated daily to meet their full nutritional needs until enteral feeding is fully established.
Okay, that covers preterm care extensively. We shift now from the sort of accident of timing prematurity to the pathology of restricted growth happening before birth. Fetal growth restriction, or FGR. You mentioned earlier it's often incorrectly used interchangeably with small for gestational age, SGA. Why is really understanding this nuance so vital for the clinician, for the professional listening?
This is perhaps one of the most crucial distinctions for you to master from this deep dive. It fundamentally changes management and prognosis. Fetal growth restriction, FGR, is defined, yes, by a birth weight below the 10th centile for gestational age. But specifically, when that small size is caused due to an underlying pathological process that prevented the fetus from achieving its genetically determined growth potential.
Okay, pathology is the key.
Right. The overlap is the clinical challenge. When we screen a population using ultrasound or birth weight, about 70% of infants found to have a weight below the 10th centile are simply SGA, small for gestational age. They are constitutionally small, often reflecting maternal size or genetic factors, but they are healthy. They have fulfilled their inherent growth potential. They are generally not at increased risk for the complications we associate with FGR.
So SGA is small but healthy, met potential.
Exactly. It is the remaining 30% within that below 10th centile group that are truly FGR. They are pathologically small because something went wrong, placental insufficiency, infection, genetic abnormality. They did not reach their growth potential. And these are the infants who face exponentially increased risks of perinatal morbidity and mortality, both short-term and long-term. Distinguishing them is paramount.
Okay, so SGA, small, likely genetically determined, healthy. FGR, small, sick due to a specific pathology, did not reach potential, that's clear.
Precisely. And the type of pathology, particularly when it occurs during gestation, often dictates the baby's physical proportions. This leads us to the two fundamental types of FGR, which are categorized broadly by the timing of the growth insult.
Let's start with the less common type, but often the more serious one, symmetrical or early onset FGR. This accounts for about 20% of cases, the source says.
Yes, symmetrical FGR occurs when the insult happens very early in gestation, specifically during the phase of cellular hyperplasia. That's the period when the body is primarily growing by increasing the number of cells.
Okay, increasing cell number.
So because the insult, maybe it's a significant chromosomal abnormality. A severe early congenital infection like CMV or profound early onset maternal disease happens when the fundamental cell number is being determined. The total cell number ends up being permanently less across all organ systems. Brain, liver, body, everything is affected relatively equally. This pathology is often considered intrinsic to the fetus itself. Since the growth of the head and the body are affected proportionally, the fetus is uniformly small. Therefore, the head circumference to abdominal circumference, HCAC ratio, is usually normal. Everything is small together. The ponderal index, PI, which measures leanness, might also be normal because there isn't necessarily wasting. But because the fundamental cell count, the building blocks, is compromised from early on, the long-term prognosis for symmetrical FGR is generally considered poorer.
Okay, that makes sense. Early insult, fewer cells overall, poor prognosis. Conversely, the majority, about 80%, is asymmetrical or late onset FGR.
Correct. This form is typically a direct result of a stressful or deficient environment later in pregnancy. The insult happens later, usually in the late second or third trimester, during the phase of cellular hypertrophy. This is a period when cells are primarily growing by increasing in size, not number.
Increasing cell size.
Right. So the total cell number is already set and is usually normal. But the cells themselves end up being smaller due to a chronic lack of resources, oxygen, and nutrients. The pathology here is typically extrinsic to the fetus. It's usually caused by maternal diseases like preeclampsia, chronic hypertension, or placental problems that lead to chronic placental insufficiency. Essentially, the supply line of oxygen and nutrients via the placenta becomes restricted late in the game.
And this external restriction, this lack of supply, leads to that classic fetal compensatory mechanism you hear about, the brain-sparing effect.
Exactly. The fetus, facing chronic hypoxemia and nutrient restriction, makes a life-saving adaptation. It prioritizes survival by shunting the limited oxygenated blood flow away from less immediately vital organs, like the liver, the gut, the subcutaneous fat, the kidneys, and directing it preferentially towards the brain, the heart, and the adrenal glands.
Protecting the crucial organs.
Precisely. Clinically, this means the head growth is relatively preserved, while the abdominal growth, largely determined by liver size and subcutaneous fat, lags significantly behind. Therefore, the HCAC ratio becomes elevated. The head is larger relative to the small abdomen. The ponderal index, PI, that measure of weight relative to length, is often low, indicating wasting or lack of fat deposition. But importantly, because the underlying cell number, particularly in the brain, is usually normal, the prognosis for asymmetrical FGR is generally better than symmetrical FGR if the condition is recognized and delivery is timed appropriately before severe, irreversible damage occurs from the chronic hypoxia.
That distinction is very clear now. Let's dive into the specific etiology of FGR, the causes. The sources group them into 4 categories. Which maternal factors are the most potent restrictors of fetal growth?
Maternal factors are incredibly common and diverse. They certainly include constitutional factors, naturally small women, women with a low pre-pregnancy body mass index, BMI, but more pathologically, profound poor maternal nutrition leading to chronic deficiency in essential substrates like glucose, amino acids, and oxygen is a major factor, especially globally.
Right.
Crucially, significant maternal diseases are major contributors. Chronic hypertension, preeclampsia, especially early onset, chronic renal disease, cyanotic heart disease, severe anemia, thrombotic disorders like antiphospholipid syndrome. All of these can compromise uteroplacental blood flow, and we absolutely cannot forget maternal toxins. Alcohol consumption, heavy smoking, and use of illicit drugs like cocaine or narcotics are powerful vasoconstrictors and directly limit nutrient and oxygen delivery to the fetus, causing significant growth restriction.
Okay. Next category, fetal factors. These seem to involve structural or genetic issues within the fetus itself, preventing it from utilizing the available substrate, even if the supply from the mother and placenta is theoretically okay.
Exactly. Here, the problem lies within the fetus's own ability to grow. This could be due to major structural anomalies, particularly severe cardiac defects or renal anomalies. Chromosomal abnormalities are a significant cause, found in perhaps 8 to 12% of growth-restricted infants. The classic examples are trisomy 13, Fetal syndrome, 18 Edwards syndrome, and sometimes 21 Down syndrome, although growth restriction is more severe in 13 and 18.
Okay, trisomies 13, 18, 21.
Also under fetal factors are congenital infections. The Tourse agents are the classic ones. Toxoplasmosis, others like syphilis, varicella, rubella, cytomegalovirus, CMV, herpes simplex virus. These often cause early, severe, symmetrical growth restriction, along with other abnormalities. Malaria is also a major cause in endemic areas. And finally, multiple pregnancies like twins or triplets inherently cause some degree of growth restriction simply due to the excessive demand on maternal resources or sometimes unequal placental sharing.
Makes sense. The third group, placental factors, defines the failure of the supply line itself, the placenta.
Yes, this is the core of chronic placental insufficiency. It's the inability of the placenta to adequately perform its vital transfer functions, delivering nutrients and oxygen, removing waste products over a prolonged period. This can result from problems with placental development or damage. Examples include extensive placental infarction, tissue death, chronic abruption, partial separation, placenta previa covering the cervix. Abnormalities like circumvallate placenta or conditions like placental mosaicism, genetic abnormalities confined to the placenta, anything that damages the placenta or reduces its effective surface area.
Then the fourth category.
The fourth category is, perhaps frustratingly, unknown. We must acknowledge that despite thorough investigation, the specific etiology of FGR remains unknown in a substantial proportion of cases, maybe up to 40%, according to our source. It just underscores the complexity of regulating fetal growth.
It certainly does. Finally, what's the clinical picture? What does the pathologically restricted FGR neonate actually look like at birth, and how might you visually distinguish them from a preterm baby who might be the same weight?
The basic underlying pathology is that reduced nutrient and oxygen availability. This leads to consequences like reduced glycogen storage in the liver, making the abdomen small, and reduced overall cellular growth. A significant associated finding, particularly in late-onset FGR, is oligohydramnios, low amniotic fluid. This happens because chronic hypoxia causes the fetus to reduce blood flow to the kidneys, leading to decreased fetal urine output, and fetal urine is the main source of amniotic fluid in later pregnancy.
Ah, low fluid due to less urine.
Right. Clinically, these FGR infants often have that classic old man look or wasted appearance. They show a severe weight deficit, often 600 grams or more below the minimum expected weight for their gestation. Their skin appears dry, loose, and wrinkled, sometimes peeling. That's due to the significant lack of subcutaneous fat. They often have a scaphoid or sunken abdomen because the liver is small and there's little abdominal fat. The vernix caseosa, that cheesy coating, might be thin and possibly meconium-stained, greenish if they experience distress. The umbilical cord often looks thin and poorly nourished.
Okay, that's a distinct look.
But here's the key functional distinction from a typical preterm baby of similar weight. Neurologically, the FGR infant, especially the asymmetrical type, is often surprisingly alert and active. They might have a vigorous cry and relatively normal reflexes, reflecting that brain-sparing effect. The preterm baby, in contrast, is often hypotonic, lethargic, and has weaker reflexes due to global immaturity. #TagCheck6, diagnosis and management of FGR. Okay, so we've identified this FGR baby. The management then becomes fundamentally about intensive fetal surveillance. It really boils down to performing a continuous, often difficult, life or death calculus, carefully balancing the ongoing risks of keeping the baby in that hostile intrauterine environment with chronic hypoxia versus the risks associated with premature delivery and subsequent neonatal complications.
And the diagnosis, or at least the suspicion, often begins with simple screening methods in the prenatal clinic, right?
Yes, absolutely. Basic screening relies heavily on serial symphysis fundal height, SFH measurements. After about 24 weeks of gestation, the fundal height measured in centimeters should correlate fairly closely with the gestational age in weeks. For example, 28 centimeters at 28 weeks. A lag of 3 centimeters or more, or static growth over several weeks, should raise a strong suspicion of growth restriction and trigger further investigation. Stationary maternal weight gain can be another simple clue, although less reliable on its own.
But ultrasound is really what brings the necessary precision to detect FGR and, importantly, attempt to distinguish SGA from true FGR and symmetrical from asymmetrical types.
Ultrasound is absolutely non-negotiable once FGR is suspected. It's the cornerstone of diagnosis and monitoring. We look at various biometric measures. The abdominal circumference, AC, is considered the single most sensitive parameter for detecting FGR. Why? Because, as we discussed, abdominal growth is highly dependent on liver size, glycogen stores, and subcutaneous fat deposition, both of which are reduced early and significantly in response to nutrient restriction and hypoxia.
AC is most sensitive. Okay.
Yeah. We then rely heavily on calculating ratios to assess proportionality. The HCAC ratio, head circumference to abdominal circumference, is key. An elevated HCAC ratio strongly suggests asymmetrical FGR, reflecting that brain-sparing effect where head growth is preserved relative to abdominal growth. A normal ratio might suggest symmetrical FGR or a constitutionally small SGA baby.
HCAC for asymmetry.
We also often look at the femur length, FL. Sometimes an FL to AC ratio, FLAC, greater than 23.5 is used as another indicator suggesting FGR, as long bone growth can also be affected, though usually later than abdominal growth in asymmetrical FGR. And the ponderal index, PI, can be estimated using ultrasound measurements of fetal weight and length. That's calculated as estimated fetal weight in grams divided by the cube of the crown heel length in centimeters times 100. A PI below the 10th centile is highly suggestive of FGR, particularly the asymmetrical type with wasting, helping distinguish it from a symmetrically small but proportionally grown fetus.
Right. And the amniotic fluid volume assessed by ultrasound gives us another important indicator of fetal well-being or distress.
Yes. Oligohydramnios, or reduced amniotic fluid volume, is frequently associated with late-onset FGR. As we said, it often reflects reduced fetal urination secondary to chronic hypoxemia and redistribution of blood flow away from the kidneys. We measure this using ultrasound. We look for either the single deepest vertical pocket SDVP, a fluid if it's less than 1 or 2 centimeters, that's concerning, or the amniotic fluid index, AFI, which sums the deepest pocket in 4 quadrants if the AFI is less than 5 centimeters. That indicates oligohydramnios. Finding oligohydramnios in the context of suspected growth restriction is definitely a red flag, suggesting significant ongoing placental insufficiency and increased fetal risk.
Okay. Now we move into the really advanced surveillance techniques that elite professionals rely on heavily, Doppler ultrasound parameters. These seem to be the backbone of monitoring fetal condition and critically timing intervention. How does the Doppler sequence typically map the cascade of fetal compromise as placental function deteriorates?
Doppler studies are fascinating. They don't just look at size. They measure blood flow velocity and resistance within key fetal and placental vessels. They paint a dynamic picture of how the fetus is adapting or failing to adapt to the restricted environment. And yes, there's often a predictable sequence of deterioration. Step 1. Umbilical artery, UA Doppler. This is usually the initial and primary surveillance tool, as recommended by bodies like RCOG. We look at the blood flow waveform in the umbilical cord artery during the fetal cardiac cycle. Normally, there's good forward flow throughout, both systole and diastole. An early sign of trouble is increased resistance in the placental vessels, which manifests as decreased end diastolic velocity, less forward flow when the fetal heart is relaxing. This indicates that the placenta is becoming increasingly difficult to perfuse, hindering oxygen and nutrient exchange.
Okay, UA Doppler first shows increased resistance.
Step 2. If the UA Doppler becomes abnormal, we then interrogate the middle cerebral artery, MCA Doppler, in the fetal brain. Normally, the brain vessels have relatively high resistance to flow. However, when the fetus experiences significant hypoxemia, it triggers that cerebral vasodilatation. The brain vessels relax to allow more blood flow in. This is the brain staring reflex visualized on Doppler. This manifests as increased diastolic velocity, more flow during cardiac relaxation in the MCA, or a decreased pulsatility index, PI, in the MCA.
MCA Doppler shows brain sparing.
Step 3. We can then combine these findings into the cerebral-placental ratio, CPR. This is calculated simply by dividing the pulsatility index, PI, of the MCA by the pulsatility index, PI, of the UA, MCA, PI, UA, PI. A decrease in the CPR index is considered a more sensitive indicator of impending fetal compromise than looking at either the UA or MCA Doppler alone. It shows that the brain is vasodilating, while the placental resistance is increasing, a sign the fetus is actively compensating for significant stress.
CPR combines MCA and UA for more sensitivity. Okay, so the fetus is compensating, shunting blood to the brain. But that compensation must have its limits. The most critical sort of end-stage Doppler sign mentioned is absent or reversed end diastolic velocity, AREDV. What does that signify?
AREDV in the umbilical artery is indeed a severe danger sign. It represents a critical progression of placental insufficiency. Absent end diastolic velocity, AEDV, means the placental resistance is so high that blood flow effectively stops in the umbilical artery during fetal cardiac diastole. Reversed end diastolic velocity, REDV, is even worse. It means the resistance is so high that blood flow actually reverses direction back towards the fetus during diastole.
Flow goes the wrong way.
Exactly. This signifies critical fetal jeopardy and is strongly associated with poor perinatal outcomes, including stillbirth and neonatal death. Why is reverse flow so catastrophic? It strongly predicts moderate to severe fetal acidosis. It indicates that the fetal heart is significantly struggling to pump blood forward against this extreme resistance, reflecting profound cardiovascular compromise and often near end-stage cardiac failure. Finding AREDV is usually a strong indication for urgent delivery.
That's a very ominous sign. If RDV is present, or if things are worsening rapidly, is there a final monitoring tool, another Doppler vessel, used to help determine the exact timing of delivery, perhaps differentiating hours from days?
Yes. If the umbilical artery Doppler is severely abnormal, like AREDV, and we're trying to decide just how urgently delivery needs to happen, particularly at very preterm gestations where every extra day in utero counts, we often then examine the ductus venosus, DV Doppler. The ductus venosus is a critical fetal vessel that shunts highly oxygenated blood from the umbilical vein directly through the liver to the fetal heart and brain.
Yeah.
It's a key regulator of central oxygenation.
Okay, ductus venosus.
Abnormal flow patterns in the DV, particularly significant reverse flow during the A wave, which corresponds to atrial contraction, suggests severe cardiac compromise and diastolic dysfunction. It indicates that the fetal heart is failing under the strain, and this finding correlates strongly with fetal acidemia, low blood pH, and increased risk of imminent demise. Abnormal DV Doppler findings are often used as a critical deciding factor for the immediate timing of delivery, sometimes accelerating the timetable regardless of gestational age because the risk of staying in utero has become too high.
That's incredibly sophisticated monitoring. Turning now to general management, the source material states quite clearly that there is really no proven therapy for reversing established fetal growth restriction. So management seems largely supportive and focused on monitoring and timing delivery.
That is largely correct. Once FGR is established due to underlying pathology, we don't have a magic bullet to fix it. For the 70% or so who are ultimately found to be just constitutionally SGA, close monitoring to ensure they are just SGA is usually sufficient, with no intervention needed. For true FGR, particularly the symmetrical type, investigation into the underlying cause, like genetic testing for anomalies, screening for infection, is important for counseling and prognosis. For the more common asymmetrical FGR due to suspected placental insufficiency, management focuses on optimizing the intrauterine environment as much as possible while intensely monitoring the fetus for signs of deterioration.
Okay, optimizing the environment. How?
Non-specific therapies are often tried, although evidence for major impact is limited. Adequate bed rest, particularly resting in the left lateral position, is often recommended. The theory is this maximizes uterine blood flow by taking the weight of the uterus off the major blood vessels.
Left side rest.
Correcting any overt maternal malnutrition is crucial, aiming for perhaps 300 extra calories per day if deficiency is suspected. And rigorous avoidance of smoking, alcohol, and other toxins is absolutely non-negotiable. For selected high-risk cases, like women with recurrent severe FGR, or certain underlying conditions like hypertension or antiphospholipid syndrome, clinical trials have looked at things like maternal hyperoxygenation, giving the mother supplemental oxygen, maybe 2.5 lemon by nasal prongs, or low-dose aspirin, like 80-81 milligrams daily, started early. The goal is usually short-term pregnancy prolongation, but strong evidence for reversing established FGR is generally lacking for most interventions.
Okay, so this brings us inevitably to the ultimate intervention, the timing of delivery. This really seems like the critical juncture where all the monitoring data comes together and clinical expertise is truly tested.
Timing is absolutely everything in managing FGR. It's the crux of the matter. For uncomplicated, mild FGR where Doppler studies remain reassuring, delivery can often safely wait until term, 37 weeks or later.
Okay, 37 weeks if mild.
However, we typically intervene earlier, usually recommending delivery sometime between 34 and 37 weeks, when FGR is complicated by additional maternal or fetal risk factors. These factors would include things like the development of oligohydramnios, worsening maternal preeclampsia, or abnormal but not yet critical Doppler findings, like consistently elevated UA resistance but before AAGV develops. The goal is to deliver before severe compromise occurs, but after achieving reasonable maturity.
34, 37 weeks if complicated. And what specialized pharmacologic interventions are required when that necessary early delivery is being contemplated, especially before 34 weeks?
Two key interventions are essentially mandatory if delivery is anticipated before 34 weeks gestation, aimed at improving neonatal outcomes. First, a full course of antenatal corticosteroids, like betamethasone or dexamethasone, is given to the mother, usually as 2 injections 12 or 24 hours apart. The primary goal is to accelerate fetal lung maturation, reducing the incidence and severity of respiratory distress syndrome, RDS. But crucially, steroids also have proven benefits in reducing the risk of intraventricular hemorrhage, IVH, and necrotizing enterocolitis, NEC.
Steroids for lungs and brain.
Second, if delivery is anticipated before 32 weeks gestation, magnesium sulfate is typically administered intravenously to the mother for fetal neuroprotection. Multiple large trials have shown that maternal magnesium sulfate given shortly before very preterm birth significantly reduces the risk and severity of cerebral palsy in the surviving infants.
Magnesium before 32 weeks for neuroprotection. Okay, and when does the definitive, almost unavoidable cutoff for delivery occur based on those most severe Doppler findings we discussed?
Delivery is generally indicated definitively at $340 and $77 weeks of gestation, 34 weeks exactly, in cases that have additional risk factors, even if Dopplers aren't critical yet, because the balance of risk shifts significantly towards delivery at that point. However, delivery is indicated at any gestation, after viability, typically considered 23-24 weeks, whenever those ominous signs of profound circulatory distress appear, particularly the presence of absent or reversed end diastolic velocity, AOR-EDV, in the umbilical artery, or critically abnormal ductus venosus waveforms suggesting impending acidemia. Once those signs appear, the risk of intrauterine fetal demise is considered too high to safely continue the pregnancy, regardless of the gestational age.
Right, a clear line in the sand.
Yeah.
Finally, the delivery method itself. This requires extreme caution, you mentioned, because of the high risk of these compromised fetuses not tolerating labor well, the risk of intrapartum asphyxia.
Absolutely. The delivery must occur in a tertiary level center, a facility fully equipped with advanced neonatal intensive care unit, NICU capabilities, ready to resuscitate and manage a potentially very sick infant. Intrapartum monitoring during labor, if attempted, must be continuous and meticulous, both clinical monitoring and continuous electronic fetal heart rate monitoring, CTG. These fetuses have very limited physiological reserves.
Close monitoring during labor.
Vaginal delivery can certainly be considered and attempted, especially if the gestation is beyond 34 weeks and the cervix is favorable, ripe and ready for induction or labor. However, the threshold for resorting to cesarean delivery is generally much lower for FGR fetuses compared to normally grown ones. Cesarean delivery is often necessary or planned from the outset when the assessed risks of attempting vaginal delivery are considered too high. This would include situations involving evidence of fetal acidemia before labor, the presence of REDV on recent Dopplers as these fetuses tolerate contractions very poorly, a very preterm gestation, or an unfavorable cervix where a long induction might be required. The priority is always a safe delivery for a very vulnerable baby. #tag7. Conclusion and final thought.
So, after that incredibly detailed journey, what does this all mean for you, the elite learner aiming to master this? We've clearly established that managing the small infant, whether preterm or growth restricted, it really transcends simple definitions based on weight alone. It demands a sophisticated mastery of precise measurement against gestational age, yes, but also the sequential interpretation of complex Doppler surveillance, and a meticulous, protocol-driven approach to stabilizing every single immature system from the lungs and heart to the brain and gut.
Exactly. We've hopefully crystallized that crucial clinical distinction between the constitutionally small, generally healthy, small for gestational age, SGA baby, and the pathologically restricted, high-risk fetal growth restriction, FGR infant. Recognizing that only the latter carries that severe intrinsic morbidity risk is fundamental. We've also detailed how the global systemic immaturity of the preterm baby necessitates that intensive, highly controlled environment. Everything from maintaining a stable, humidified thermal environment, to employing specific trophic feeding strategies to prime the gut, to vigilantly adhering to those very narrow oxygen saturation and ventilatory monitoring targets to avoid iatrogenic injury like ROP or BPD.
Right. For you, our listener, mastering this material means deeply understanding the interconnected systemic risks. Recognizing, for instance, how hypoxia leads to acidosis, which can precipitate devastating intraventricular hemorrhage, IVH, in the fragile preterm brain, or understanding that an elevated HCAC ratio isn't just a measurement, it's the physical manifestation of fetal brain sparing under duress, and that seeing AREDV on a Doppler scan signals profound circulatory collapse in the FGR fetus, demanding urgent action.
And all of this detailed understanding of the immediate challenges raises, I think, an important final question for you to consider as you integrate this knowledge. While our source material focuses heavily, and rightly so, on the immediate diagnosis and management for survival, it also clearly notes that the long-term risk for the FGR infant, in particular, is profound. We mentioned that increased risk of developing metabolic syndrome, obesity, hypertension, and diabetes in adult life, the DOHED concept. So the provocative thought is this. Given that our improving neonatal and obstetric care means more of these very high-risk infants are surviving, what broader health economic strategies and public health initiatives must be implemented today to effectively manage the inevitable long-term chronic disease burden that may result from successfully saving these pregnancies now? How do we support the lifelong health of these individuals we work so hard to save at birth?